in the spirit of reconciliation, respect the self-determination of First Nations, Métis, Inuit, and their rights and responsibilities in culture, language, and the pursuit of wellness. I would also like to acknowledge the traditional lands that each of you are joining us from today. Thank you. I'll pass it back to Selena.
Thank you, Jocelyn. Next slide, please. All right, so just a quick recap. A couple of weeks ago, the Council of Network met on February 7th, and this was part one of this workshop. We introduced you to the 6-step guide, the pathway to implementation. Mo Donald, one of the co-PIs for one of our phase 2 projects, talked about how the management team was using the pathway to implementation guide. We also heard from 4 other projects about what their implementation plans were and what have been their efforts so far. So we heard from the 4 teams about where they were along the pathway, what was working, where they were struggling, and what supports they were looking for. Next slide, please. So just a quick recap. This is what we heard from the self-management team. So they completed the initial implementation of a website that they developed. It's called My Kidneys, My Health in phase 1. Their objectives for phase 2 is now to adapt that website. And so they're currently at step 1 along the pathway. They're meeting with different groups to start creating awareness and interest in this website. In terms of their implementation efforts that have worked so far, the group told us that they had some really good networks and engagement activities with primary care and allied health that they're able to leverage for phase 2. They have strong dissemination plans from phase 1, which have led to building new relationships and partnerships. And they're currently working with Catherine Turner for support and guidance around how they can best engage with Indigenous communities. In terms of where they see some challenges going forward, I think starting to engage with Indigenous communities and what opportunities are available. These working with Indigenous communities take time, and they're also thinking around meeting timelines, especially if we think about our phase 2 grant timelines. Next slide, please. All right, so there were a couple of things that we also heard from the 5 project teams at this first workshop. I think it's fair to say that learning and applying implementation and implementation science is not only a new topic for most of us, it's also a steep learning curve. The second thing that we also heard was that teams are at different stages and steps along the pathway. Sometimes it's not that easy or straightforward to identify exactly where they are on the pathway. And depending on some project teams, they have different objectives and they might be at different steps in the implementation pathway based on that. I think we also heard that engagement with Indigenous communities and other marginalized communities takes time. It also takes time to build trust, and I think project teams would welcome some support around this. We also heard that from some of the project teams that they're looking at some tech and IT considerations, and it would be good to also get some support around that area. Next, please. Okay, so why are we here today? So the bulk of today's session is going to be a focused discussion with the remaining 4 project teams: ProKid, Increasing Living Kidney Donation, the Deprescribing Project, Stop Med HD, and Mind the Gap. So very similar to what we did at the February 7th workshop, project teams are going to tell us, they're going to answer the 3 questions. They sent their responses in advance, so we'll use, we'll showcase some slides with their responses, and Stephen will lead the discussion. And then we'll also do a quick review at the end, time permitting, a quick review of what the other projects had basically said. And then we'll have some time for Q&A at the end. Just a quick reminder for all of you who have participated and have taken the time to look at the pathway and answer the questions. A lot of this work that you've done will really be also part of the your annual reporting and will support the forms you need to be filling out. Next, please. Okay, so what would we like from you? Come with an open mind to learn. And as you're hearing what the project teams are doing, try and think about your role supporting the projects and the network. How do you see yourself contributing to implementation efforts, right? Please ask us questions. We're all part of this larger KT community of practice, so your participation and your feedback is extremely valuable. If you don't feel comfortable unmuting yourself and speaking up, don't worry about it. Just add your thoughts and comments to the chat. And the one big message we would like to leave everybody after today is we ask you to please commit to using the Pathway to Implementation Guide over the next 3 years. Please don't let this document sit on a shelf. Please try and find opportunities to refer to it, whether it's at your team meetings, whether it's through consultations with other team members or our group. But please try to use the pathway and refer to it as often as possible. Next slide, please. Okay, so I'm now going to hand over to Dr. Stephen Soroka. Again, most of you know Stephen. He's a nephrologist. He's also one of the co-chairs of our KT committee, and he's also the Senior Medical Director of the Renal Program and Pharmacy Services at Nova Scotia Health. So I'm going to hand over to Stephen. Next slide, please. Stephen, sorry, you're on mute.
Oh, so thanks. And for some reason at work, I have a more unstable network connection than at home. So if I lose you, just let me know, and I hopefully I'll come back. Was it a program? Was it a policy? Was it something that, you know, that was more concrete? So, and it's telling me my internet connection is unstable. Anyway, so one of the things we'd ask you at the beginning, perhaps, is to say, you know, within our project, what we're planning on implementing is a practice, a procedure, a program, a something. So we're kind of clear on what it is that we're focusing in on. Next slide, please. So I want to start with ProKid. We understand that Mina has to get onto another meeting after this quickly. So we'll start with her and let her take us through the 3 questions that we asked. And again, the first thing would be, what is it that you're going to implement in PANSOL 2.0?
Thank you so much. Hi, everyone. So I'm Mina Matsuda Abedini. I'm a pediatric nephrologist. Recently moved from Sick Kids in Toronto to Vancouver. I'm currently at BC Children's Hospital, and I co-lead the ProKid project with, I see actually Rahul's name is on here, but with Dr. Allison Dart in Winnipeg. And Allison can't join us this morning, so I'm going to present on our team's behalf. So ProKid is a patient report, it stands for Patient Reported Outcome Measures in Children with Chronic Kidney Disease. And this is a PROM that we developed through cognitive interviews of children ages 8 to 18 years with chronic kidney disease, including dialysis. And the reason we had to go through this exercise is we do not currently have a validated tool available to assess the symptom burden of CKD in pediatric chronic kidney disease. So now that we've developed the tool, we are completing the validation of this tool across Canada, and we're very close to reaching our target, and we hope to present that data in Halifax as CSN. But just on the analysis that we have, the tool looks validated. So we're ready for jumping into implementation. And we were, with the support of CanSolve CKD 2.0, just last week, we held a hybrid in-person and virtual meeting with many of our investigators who are involved, as well as our patient and parent partners in Toronto. And we invited Dr. Melanie Berwick, who's an implementation science consultant, to teach us about implementation science, as well as we had the opportunity to hear from Dr. Michael Welsh, who's used the adult validated tool that many of you are familiar with, the ESAS Renal Edmonton Symptom Assessments scale that is used in the adult dialysis units in Ontario and beyond. So the purpose of this meeting was not only to hear about implementation science, but also to figure out pre-implementation, what is the work that we need to do to ensure a successful implementation. So I would say that along looking at this pathway, we're somewhere between, we're at step 1 and 2 simultaneously, meaning that we're raising awareness across Canada, and we are trying to assess the readiness across sites to see who the key players are and identify the barriers and facilitators as we launch into implementation. And the second question was, what implementation efforts have worked well? We are fortunate that the pediatric nephrology community in Canada is very collegial and collaborative. There are only 14 pediatric hospitals in Canada, and we know the community quite well. And all children with CKD dialysis transplant are followed at one of these 14 centers in Canada. So right now we are trying to identify the key individuals, meaning nurses, nurse practitioners, and the physicians who are in charge of the CKD programs at each of these sites. We're going to invite them to a focus group so that we can sort out how best to implement this ProKit tool that's quite easy to complete. It's 14-item questionnaire. It takes 5 minutes to complete. And I think the key for us, and I would love to hear from the group who has successfully moved on to further along the pathway of implementation in terms of there are different IT systems at each of these sites. EMRs are different, Epic, CSD, Cerner, et cetera, of how best to implement this tool seamlessly into the various electronic medical records that exist at different sites, and how best to capture the data kind of short-term and long-term. And then the other question that I'm hoping for some guidance is around whether this type of implementation can be considered a QI project, or do we need to go at each of these sites and obtain RAB approval if we are going to implement this as part of clinical care at each of these sites. So that's where we're at with the project. And I'm open to any questions.
So Mina, can I ask you though, have you gone through and I guess for lack of a better word, sort of beta tested this at one of your sites to show that it is actually a proof of concept?
So Stephen, I'm not sure in terms of the proof of, so is it, are you asking whether we have, so for the validation of the tool, the validation is actually happening at 5 of the sites across Canada. So we have, as part of the validation at all these sites, we have been administering the tool together with PEDS QL, which is a quality of life, validated quality of life tool in our dialysis units and in our CKD clinics. So we know that it's easy to complete. We know that it does assess the symptom burden. And then separately, which I didn't actually include here, but separately, it's going to be administered longitudinally as part of an NIH-funded CKIT study where 800 children in the United States are followed longitudinally to make sure that the clinical sensitivity is there in terms of picking up the increased burden of disease during progression from stage 2, 3, 4, all the way to dialysis. So that's kind of happening separately as well.
Yeah,
So
so let me rephrase the question.
Yes.
Let me rephrase the question. So is the intent by the end of CANSOLV 2.0 to have fully implemented and evaluated and sustained this in all 14 pediatric places in Canada? Or is it to sort of say we've got 5 that we've implemented, we've evaluated, and we have sustainability in those 5, and then that would be sort of like the toolkit that would be offered up to other centers in Canada to go forward and do the same thing?
So the readiness, the focus group that we're working on right now and the whole readiness assessment, the goal is to see whether we can identify the kind of the core sites that can easily or seamlessly implement this quickly. So we're hoping that it will be a phased approach, because I doubt that we would be able to kind of roll this out as you have brought up. I doubt that we will be able to do this without a glitch across all 14 sites simultaneously. But we are hoping that we can take a phased approach, or like a wave where, you know, a few of the sites, you know, Toronto, Vancouver, Winnipeg have been so involved from the get-go of this project that I think at these 3 sites it will be seamless, but then hoping that in that process we then develop the toolkit to have it go to all the other sites. But really in that part of the readiness assessment survey is to determine you know, what are all the sites where this can happen seamlessly.
Okay, all right. Great.
But I would, I don't know if anyone can help us figure out this piece about whether this type of thing is considered QI at most sites, or do we need an REB approval at each of these sites to incorporate this into clinical care? I don't know if there are any other projects that have done this. I see
Carrie has her hand up.
Yeah, I was going to say, usually it just depends on whether you want to publish or not. Honestly, it comes down to that in a lot of these sort of questionable. In my experience, the question I always ask is, if you want to publish, many published journals, depending on where you want to publish, often require REB. Whereas if you're just looking to change practice based on evidence that already exists, which you've already sort of created in phase 1, then it would be, it could potentially be quality improvement. Melanie.
Thank you. I was just going to chime in too that if ask really, will you be testing the tool for a period of time? Because then that could be a QI, and you still may need REB approval, I think, depending on your site. But
yeah, there might actually be an expedited process for QI versus like a formal research study. So you might have to do, there might be a small amount of paperwork to do. And sometimes, you know, if it's hard to get consent from everybody, then you can sometimes have that waived as part of it. So every REB might have a slightly different process for figuring out what would be QI versus, you know, a randomized trial or something like that. So that might be something to look at.
Thank you, everyone. I mean, that was our, it's hard to know. As you can imagine, in pediatrics, we have the extra layer that we not only need the consent of the parent, we also need the assent of the child. And given that we're thinking that this is, I mean, the purpose of this is to assess the burden of symptom at each visit. And if this is going to be, we just weren't sure about whether it could be considered QI. If the idea is having this tool that's measuring symptoms at each site versus, as you mentioned, I think Carrie and Melanie both alluded to this, but you know, once we start looking at evaluation of the implementation, I mean, that's going to be research. So hard to know what is required, whether we can call it QI or is this a full-on REB for a trial type research.
Yeah, it gets back to my point about if you're going to implement, evaluate, and have it, sort of done in 3 places, then if it becomes something that you would say this is an added value to your program for clinical care, perhaps it's not research anymore. It's just implementing something that's already been implemented and evaluated and proven to be, beneficial in a small number of sites. I think the other comment is when you talk about infrastructure IT support, maybe that's something you flesh out with the ROC first year review to sort of figure out what you might need, and then who might you connect with to help you sort out what that might look like from what you're needing. Because I think that's another important piece if you're trying to aggregate a bunch of data from different source systems versus are you going to do a separate data collection and evaluation, or I'm not sure what you're meaning by that. So maybe something to flesh out a bit more on what you're looking for there.
Great, thank you so much.
All right, thank you
Jim,
very much.
I see Jim has
a hand up. Yes.
hand up.
Yeah, so Mina, I was just wondering, based on that discussion, whether just to talk to Jeffrey Johnson in Edmonton or Mike actually at MAC and just see what they faced, because they initiated their PROMS project across many institutions, and how did they frame it at each of those institutions when they began to apply it in the various dialysis units? Did they go between QI or did they go like around RCT, and see what challenges it might be helpful? And then of course Mo McDonald with her experience might have broader experience with other implementation strategies. So I might suggest those 2 resources as something to consider.
That's a great suggestion. Thank you, Jim.
All right, thank you very much. So we'll move on to the next next slide, please. And this is the increasing living donor kidney transplant with Kyla, I guess, is going to be presenting on behalf of the project team.
Yeah, thank you. So I'm Kyla and I'm a researcher out of London, Ontario, and also actually presenting with me will be Sue as well. So we'll be doing this presentation together, but I can start us off. So for phase 1 of this work, the overall goal of the project was to increase access to living kidney donor transplant. And then with phase 2, we're really trying to achieve more living kidney donor transplants. So with phase 1 of this work, there were 2 major components. That was to improve the efficiency of evaluating the living donor evaluation and to improve access to kidney transplant. So in phase 2, one of our key goals is to develop and disseminate benchmarks for an efficient living donor kidney evaluation. And this is working off of our phase 1 work, in which a survey was distributed to see what kind of key benchmarks should be looked at, and then to translate these metrics for an efficient living donor evaluation into scorecards. For this objective in particular, we're up at step 1. So we're currently working with a bunch of different organizations across the country with the goal of really having a consensus conference, hopefully at the end of 2023, getting a bunch of stakeholders together. So for example, Canadian Blood Services, patients, living kidney donors, and healthcare workers across the country to help really develop, I guess, choose some select benchmarks that will be hopefully then put into scorecards and given with the ultimate goal that these scorecards will be given across Ontario and then potentially to other provinces as well. Our next objective is to translate the results of our process evaluation, which is looking at evaluating our randomized clinical control trial to enhance access to kidney transplantation and living kidney donation within the province of Ontario. So we're doing a process evaluation to really understand the fidelity, what parts of the trial worked well, which parts didn't. So this trial was composed of 4 components: education, the Transplant Ambassador Program, which Sue will speak to, and a quality improvement initiative, and as well as administration and funding to support this. So we're looking to evaluate the results of this and then seeing what worked well, and then potentially implementing certain components of this in other provinces and starting to discuss with other provinces once we get those results. So for this objective, we're primarily at step 4, and maybe I'll have Sue speak specifically to the Transplant Ambassador Program, which was the component of the trial, which is patient-led, in which donors, living kidney donors and patients who received a transplant provide mentorship to patients who are potentially considering transplant and can kind of guide them through the steps. So Sue, maybe if you want to say anything about TAP's step.
Yeah, no, I guess just, you said most of it, just that we are currently expanding and doing a pilot in Nova Scotia with respect to the TAP program that will start next March and April, this March and April coming up in the next few weeks. And just really continuing with the expansion of the program. We have 180 ambassadors across Ontario, and we also launched a new initiative called Patients Seeking Donors, which is a platform where patients can post their need for a living donor. And we've had a lot of connects so far on that site, and that is national in scope. So there's certainly a lot of activity and a lot of expansion with respect to TAP.
And then the last objective for our phase 2 canceled work is to test and evaluate solutions to improve the efficiency of the living kidney donor evaluation. So specifically right now in Hamilton, we have a 1-day donor clinic that is currently underway, and we're working on developing the analysis plan, collecting the data so that we can evaluate how this program worked. And that would put us at kind of step 5, the evaluation piece. And ultimately, if it found that this 1-day donor clinic is beneficial, then discussing with other sites within Ontario and potentially nationally as well about implementing this 1-day donor clinic. And then in terms of what it seems to be working very well with our implementation, so Sue kind of started mentioning this, our patient partners forming the Patient Partner Coalition. So we have more than 10 patients on this, and they'll be really, I think, key in disseminating the knowledge that is gained from not only our phase 2, but also our phase 1 projects. And then as well, implementing some of the strategies that have that we decide to implement. Stu, I don't know if you wanted to say a few more words about the coalition, what's been done so far.
Yeah, no, that's great. Kathleen Brown Blake, who's also working with our team and part of Amit's and Kyla's research group, has helped us pull together a very robust knowledge translation plan that is really about I can't say it. I'm not going to be able to spit out those words. I'm not going to do it. This is crazy. I can't say it, but operationalizing, there, I got it out, operationalizing the, you know, our efforts and our reach out, including, you know, three different groups, which would include clinicians and researchers, kidney patients, as a second group, kidney patients and donors, and also health policymakers. So we'll be targeting all three of those groups and have deliverables and action items that were outlined for each of those groups. And our patient coalition will be taking a really active role in that reach out, and you know, kind of boots on the ground, in a boots on the ground kind of way. So I think that's, you know, nutshell of it.
Great, thanks, Sue. And then last, where are we struggling? I think just having more support on strategies on how best to engage with Indigenous communities would be helpful for this project to ensure that we're not missing that important piece. So thank you.
Thank you very much. Yes, I would suggest, based on last week, that engaging with Indigenous communities is a recurrent theme that we're seeing. And so I would say we probably need to think about some more strategic work around that part of it for all of the projects that have that as part of their project. So I know, Selena, we've talked a little bit about that. And I think we will continue to sort of figure out ways to work around that, given that we have relatively short timelines. You know, the first year is already gone pretty soon. So yeah, we'll have to get on with that. Selena, any comments?
No, I think you've covered most of this. This project has a very engaged group of patient partners who are really taking the lead on so many things. So I think for all of us, we're really excited to see how this group is going to engage with patient partners and what is implementation going to look like. And the roles patient partners can play in that. I suspect it would be just very similar to what we've seen with TAPSU, engaged, you know, taking the lead in many areas. So very excited to see how things evolve for this project. Kayla, just a quick note, you have engaged with Catherine Turner, right?
Yeah, we still need to engage with her more, or engage with her, sorry. So yeah, that's something that we can definitely do to follow up with. Sue, did you have something to add?
Yeah, just that we also have Mary Bocage on the, you know, on our group as a co-lead and as part of the coalition. So obviously she's been instrumental in always keeping that top of mind and providing input as much as possible. So not very many conversations we have that don't consider that, but I know that there's lots of ways that we need to do better with that.
Yeah, this is definitely on our radar. And yeah, I will have a chat with Heather and with Catherine, Jocelyn, Craig, and we will absolutely get back to you.
Okay, Jim.
Thanks very much, Stephen. This is a question for Sue. I was just interested, you, in a sense, of established a toolkit, your work you do with your TAP program that's been so established in Ontario. How did you reach out to Nova Scotia? How did your initial stages in terms of establishing an implementation team for the TAP program in Nova Scotia? What was because it's so patient driven, but of course anchored in the transplant programs. What did you do for that?
Thanks, Jim. I mean, actually, we've done a lot of presentations related to TAP, and Lisa Martin, who runs the donor program in Nova Scotia, was on one of those calls and reached out to me to ask about the possibility of expanding to Nova Scotia. You know, and so we had some meetings with her group, and really, you know, because of you know, the size and scope in terms of what they were looking at, we kind of are agreed to move forward as almost like a bit of a franchise operation. So we're really just including it as an additional hospital. We already have 27 hospitals in Ontario. So adding the Queen Elizabeth II Hospital and recruiting their own group of ambassadors. We'll add some specific information related to Nova Scotia and transplant on our resource hub. And yeah, and we've had great success so far in recruiting, and I think we have a team of 8 already established. So it was just a great serendipitous opportunity, I guess you would say, that came forward.
Heather,
Thank you.
Hi, thanks very much. I was just going to suggest that there seems to be a lot of interest in engaging with Indigenous communities and getting some guidance here. And what we could consider doing is a separate session specifically on engaging with Indigenous communities with Catherine and Jocelyn and our Indigenous initiatives team. And we could also speak more about capturing Indigenous measures of success. And our late breaking news is that abstract was just accepted at CSN. So we're very excited about that.
and Heather, I was just remembering that document that we looked at in the summer fall on the engaging with all the steps that were involved. I think that's brilliant as well, right?
Mm-hmm. Yeah, for sure.
Because if everyone wants to remember, there's the pathways to implementation, and there's the implementation toolkit. There's the engaging Indigenous communities, and then there's also the EDI work, and all of that has to mesh together. So that would be layered on top of the implementation pathways, those two other areas. So. All right, we're going to move on to the next, which is the Stop Med HD. And this is Marissa Battistella. And Marissa was in Nova Scotia last week talking to us about this. But I was involved very early on in this project when they were developing some of their tools to look at how they could get a lot of the patients that are on a lot of polypharmacy off of some of the medications. So Marissa, thank you very much for joining us today and taking us through this really important project as well.
Okay, thank you. So maybe just a 1-minute background on phase 1, where we developed the tools for deprescribing. So there were 9 algorithms on 9 different medications that were validated. So we used the LIM method to validate the tools. The more exciting part of it was we also developed patient tools, so to go along with the clinical piece of it. And our patient partners helped us validate these tools. We had like an education bulletin as well as a video. And so that was kind of exciting. I think we're one of the first to do that, where our patient partners were involved in the actual research, interviewing other patients. We used the LIN method as well to validate those tools. That did come to a little bit of a stop with COVID, so we had to go back to the researcher interviewing patients, but we did collect some good information, and they've been both published. My screen is gone. Is that on purpose? Thanks. So now we're in phase 2, and so we are really at stage between steps 4 and 5. We're actually started to implement. So we've implemented at UHN. We have 3 other sites, Halifax, maybe Winnipeg, and then Vancouver for sure. So we did start at our site in the fall. So we have started in 2 shifts, the dialysis unit. And so we're just in the monitoring phase of where we've actually implemented the deprescribing program. I have a research assistant that helps, but I'm in the process of hiring another one. She's a part-time one, and so if I can get one FTE, that will help with the other sites. And when I was in Halifax, that's what we talked about, helping them hire even a 0.3 or 0.5 to help roll it out in Halifax. So what's worked well? I think, when you do go to implement, it's good to have a bit of a pilot. So we used 1 shift. Thanks, Dr. Scully. We used his shift just to get an idea of the workflow. So that really worked well. And it really is a team approach. I think it helped with the physician. Every site will be different. We have a staff physician in charge of each shift. And that was really important, that the staff physician explained it to the patient what we were doing, and then the research coordinator can go in and get consent. And I think when the staff physician has the buy-in and explains to the patient's more willing to participate. So I think that was super helpful. What are we struggling with? I think at our site anyways, we've noticed that patients are quite skeptical of any type of research. This is since COVID. Maybe other sites are finding that too. So it's really important that we do have the whole team on board to explain this so that the patient feels really well supported. I think it was a bit slow to get started with COVID interfering and stopping some of our research, but I think in the last 6 months, we're on a bit better of a roll. So I think that things should start to move a bit quicker, and hiring another research coordinator will help as well. I made a few extra notes as well that's not on here. I think one thing that would be really important for us is maybe if we created like a patient video to show the patient or tell them a little bit more about what we're doing, and from the patient's perspective. So having our patient partners participate maybe in a Q&A, we videotape it and then show patients that might help. So that's sort of maybe insights or something I can help other projects maybe suggest that they do something like that. And I think, having a good framework. So we use the REAIM framework to understand some of the facilitators and barriers which we're monitoring to implementing our deprescribing program. So I think that's really important as well. So you have this framework that you can follow and monitor. I think I'll leave it at that. Maybe people have questions.
Thank you very much, Marissa. Yes, I think we were talking that I heard that the Ontario Renal Network had done some patient podcasts to help from a patient's perspective, other patients understand what they went through as part of their journey through, their kidney health. And that actually probably is underutilized by a lot of us, that having that patient perspective. It's much like the TAP program of, talking to someone who's gone through the transplant experience is so much more valuable than having even the nephrologist who maybe is, senior transplant person, but hasn't actually gone through the process themselves. So I would say that's a really powerful thing that CanSolve could really bring to the forefront when it comes to moving the research agenda and the patient experience forward. Yeah, I think it's a great idea. Other comments? All right, thank you, Marissa. It's a great project, and I'm sure we'll be very excited to get this rolling in Halifax as well. Realizing that time is going by quicker than we ever wanted to, all the time in these sessions, we're going to go to Mind the Gap with Melanie to present her project and where they feel they are along the implementation pathway. We should call it the Golden Highway, Selena.
Hi, everyone. My name is Melanie Tolson. I'm the research coordinator for Mind the Gap for Dr. Clara Bohm in Winnipeg and Dr. Kara Shikmanaroff in Alberta. So I'm just presenting today. I'm also the new patient partnerships and capacity building manager for CanSolve. So I'm kind of wearing two hats as I transition out of my Mind the Gap research coordination role, but I'm here and happy to present on behalf of the research team. So I'll just give you the subtitle for our study so you kind of know where we're coming from. So it's Mind the Gap, Addressing Mental Health Care Gaps for Canadians Receiving Facility-Based Hemodialysis. So we have several objectives, and they're all slightly, they're interconnected, but they're also different. So it's kind of hard to plot our project along this pathway just because each objective is so different. So this is why you see so many points along our path here. But maybe I'll just give a quick little overview of our various objectives. So objective 1 is really looking at cataloging the existing mental health care resources on a national level that are specific to people receiving hemodialysis or even people with chronic kidney disease. And then and once we've generated that catalog of resources, then that will sort of trickle down towards objective 3 and implementing that along a mental health care pathway. But that's coming later. So really that catalog of resources, we kind of struggled on how to plot this on the pathway because it's something that we're not really sure if it will be implemented as such. So that's just sort of a snapshot of objective 1. Objective 2 is more around, so I've written here, creating awareness and building connections and gathering information, but that's just kind of a snapshot of where we are with objective 2. But really what objective 2 is we'll be kind of gathering information to determine what would be a good or the most desired priorities to address in mental health care for people receiving hemodialysis in facility-based hemodialysis care. So we'll be conducting different study techniques to identify those top priorities, including surveys and focus groups, and then a priority setting exercise with multiple stakeholders. So once we kind of go through that, we'll hopefully have identified the top priorities to address and also some solutions for how to best address those. So for that objective, you can see there's sort of different, we're really at the inception stage for that. So it's kind of, we've identified it as kind of on step 1, 2, 3, because we're building those connections, we're gathering information, and we're kind of planning. But eventually that one, the ultimate goal will be to test out whatever innovation is prioritized and then hopefully evaluate that, and then maybe eventually that will be implemented and rolled out. So I'm just thinking here in the interest of time, I guess so that's objective 3. 3.1 will be to develop that mental health intervention. And of course, it's too early in the project to say where that fits on the pathway, because that will be like an iterative process to even determine what intervention we'll be developing. And then 3.2 is that mental health care pathway that I spoke of before. So that one is, I think it will be developed based on the catalog of resources that is developed, but I'm not 100% sure about that. That may be something that's already underway through Kara Shikmakarov's work. So we kind of have this situation where we have these objectives and they're kind of being handled in different research sites. What else? I guess maybe just moving on to where we have found that our implementation efforts have worked well. And that's just kind of this idea of planning and compiling resources and then building connections. So for example, we have just recently engaged with an Indigenous knowledge keeper, and so she'll help guide the work. And that's something else actually that I wanted to mention too, that in objective 2, we'll also be looking at identifying those mental health care resources that are specifically targeted towards Indigenous individuals receiving facility-based hemodialysis care. But we're just limiting that to Manitoba for the scope of this research. So we're engaging with patient partners and reaching out to establish those connections with Indigenous patient partners and then also other stakeholders through Native Friendship Centers and places like that. And we've engaged also with Catherine Turner to help facilitate this. What else? Yes, and just this idea of multidisciplinary engagement. So this project seems to be quite iterative, so we don't really have the sense of where we're going yet. It will come as we build these connections and conduct the research, and we engage with all our partners, and we'll kind of feed back into what we'll be developing. So I guess that's one struggle, is just to identify, we don't have a clear path yet. And then another struggle is this notion of sustainability. So for example, that dissemination piece of this catalog of resources, I think that the plan is to have this uploaded onto some kind of website, but then who will own that? How will that be updated? Because those links and things need to be upkept. So that's one issue. And then also shifting ownership or kind of moving this from research towards system-wide implementation. There's another point that we could be facing some struggles down the road with. So that was my quick and dirty explanation. I'm out of breath. If anybody has any tips or anything, any feedback, we'll greatly welcome that. Thank you.
Yeah, thank you very much, Melanie, for that. I would suggest that it's going to be very important to get ready for that first ROC KTKU review at the end of year one, because this is a very ambitious project with lots of things going on. And I just worry that the years are going to go by very quickly. And so, you know, perhaps scaling it down into something that is going to be manageable. I mean, it's very, very important work. I just fear that it's very ambitious for the time frame that you have. But that I think it's good discussion at that ROC review at the end of year one to really dig into what you could get help with to help move it along at some point. To know if you have anyone else has a comment, Heather or Jim, maybe.
Yeah, thank you, Stephen. I would agree totally. I think the work that was going into developing the phase sheets for the phase 2 ROC will be particularly helpful, because I think they'll really, in a sense, demand that you focus on what your needs are now. And by focusing on those needs, you'll probably focus on the most important aspects of your project. I think that, and the ambition is to be applauded, but I would agree with Stephen that identifying a specific focus, I think, to advance on too broad a front will diffuse your focus and spread out your energies, and that you will have to, I think, determine where there's going to be the best bang for your buck and devote those efforts so that you can establish it. Really, I was struck as you were speaking, because there's so much you want to do and so much need in terms of mental health care. But I was struck by that slide that Stephen showed at the very beginning. What do you want to implement? What is the product? And I think returning to that in your mind and determining what those products are going to be will be really important. And I think you'll find that phase sheet that Mo and Selena and Cynthia and Stephen have helped with will be really important for you.
Thank you very much, Jim and Stephen. Those are great. I'm looking forward to digging into the ROC and having a meeting with the PIs and going through this together with them. So thank you.
All right, thank you very much. So Graham, I think in the interest of time, let's just scroll through the slides to give a sense of what we came up with from the February 7th meeting. And we can certainly provide the slides for people if they want to have them to look at, if they were not at that meeting or didn't remember what the discussion that was had. So let's just kind of go through next slide. So we heard about kidney check. Again, we talked about COVID delays with nursing support was something we need to talk about at the ROC. The next one, please. The safe CKD, again, scaling and intervention, getting out to patients, again, some COVID-related disruptions, which everyone was really hampered by. Next, please. The eye care. Here was another one around navigating IT systems and EMRs and how to look at some of that. So again, a much more, how do you work through the IT IM part of it? Next, please. Approach, again, here's another one with Indigenous community engagement. And so another, another food for thought, Heather, around getting a specific working group or a webinar or something together just to help people go through that in Indigenous community engagement work that was done so really nicely. Next one, please. Oh, that was it. And you heard about Mo Donald's one as well. So I think we have like 1 minute for questions or comments, but we will make this available to whoever wants it. And yes, I would say the next steps are going to be filling out that ROC evaluation for the end of year 1. And the KTKU part of it will be a little more expanded in that review. And that's really, I would say, because of the time frame, to really be clear about how we can help you. What do you need right now? What do you need in 6 months from now? Like, what can we do to support you? And we will be there for you. We will do what we can do to help you with this. And I speak on behalf of KTKU, and I know everyone else speaks on behalf of the CanSolve community that really want all of these projects to succeed and succeed very, very well, and to become legacy pieces for Canadian nephrology. So I'll open it up for questions. No, if not, then everyone have a good afternoon, and we'll be chatting soon if we don't see you in Halifax.
Just a quick update and just
Selena,
some
yeah.
information. We're going to be offering up 30-minute time slots for if you want to discuss your projects further with myself, Mo, Stephen. I think we'll gather some feedback from project teams as you start filling out your ROC reviews based on the conversations we've had so far. So this will allow us to maybe hone into some areas where we can provide some more supports through either more webinars, having content experts come in and talk about specific items. So we're starting to see where we might be able to continue support and where you guys might need more support. So just stay tuned, and yeah, we look forward to connecting with you. So we'll stay in touch and let you know how you can connect with us for these consultations, but you can always reach out to us.
Yeah. Okay. Bye-bye all.
Thank you.